Hi, Assalamu alaikum, good morning, where there's the morning, and good evening, where there's the evening. I wanted to present one very important topic, and topic is the basilar invagination, rheumatoid pannus. And this topic is actually very important in well, because of the lot of reasons, and I want to present like that. There's a 70-year-old female with known rheumatoid arthritis controlled with the corticosteroid presents with the several months of progressive neck pain and upper extremity weakness. She reports difficulty with fine motor task and episodic electrical shock like pain associated with neck flexion. And she reports occasional swallowing difficulty, and other notable history include osteoporosis and hypertension. Examination reveals a thin woman had mildly extended and strength. An exam revealed 4 over 5 in bilateral upper extremities and 4 plus over 5 in the lower extremities. And positive Lamide sign is the Lamide sign was positive, and asymptomatic palatal elevation 3 plus reflex throughout, and the positive Hoffman signs and the clonus positive bilaterally. My initial and differential provisional diagnosis was is a basilar invagination or some problem in the basilar area, or and because the female 70-year-old and on the corticosteroid, so I was thinking maybe because of the rheumatoid pannus, and the differential diagnosis here definitely, and something area in the atlantoaxial joint or or craniovertebral junction definitely. But differential diagnosis, if we go more in detail, definitely we find there is a cervical spondylotic myelopathy, compression fracture, atlantoaxial instability, traumatic. If I consider the traumatic, then maybe the odontoid fracture, and if I consider the neoplastic, then maybe the metastasis or the cervical spine tumor, astrocytoma, or plasmacytoma, CP angle tumor, acoustic neuroma, or meningioma, brain stem glioma, or chordoma, or chondrosarcoma. Vascular may be cavernous malformation and the vertebrobasillary insufficiency, or if I consider there the infectious, may be the discitis, osteomyelitis, or the epidural abscess. For the definitely investigation, I went for the investigation for this patient. I did the CT scan, and after CT scan, I did the MRI, and which is definitely, and I want to tell you here, the sagittal CT scan, coronal and the sagittal, both were showing there is a cervical spine reveals cranial setting with the large calcified mass posterior to the dens and resulting in the severe central canal stenosis. So the McCree line and from the basion to opistheon and the dens should not cross the line. So the Wackerham's clival canal line extension of the line draws along the slope of the clivus, and the dens should not cross the line, this line, and the Fishgold digastric line, which is connecting the digastric notch, and the distance between this line and the middle of the atlantoaxial joint, it should be less than 10 millimeter suggested. If they are less than 10 millimeter, which suggests the basilar invagination, and the Fishgold bimastoid line, and this line connecting the mastoid tip and the tip of the dens is 2 millimeter above this line on average, and atlantoaxial joint should not traverse of this line. So these are the details I told you right now. I just want to show you a little. If you see here, there is a lines which I mentioned you, the bilateral mastoid line and the other Macquarie line and the so all lines you can appreciate here, and you can see there is a invagination because of the pannus, and you can appreciate all the findings in the MRI and the CT scan. So I go further, then I want to, and I did some workup for her, such as the CBC and blood glucose, and CRP, PT, APTT, INR, ESR, and the pregabalin rheumatoid fracture. So this imaging suggests that the CT chest and the abdomen and pelvis, MRI brain, cervical spine is mandatory in these type of cases. Dynamic radiograph to evaluate for instability, and definitely we have to take the consultation for the rheumatologist and the otolaryngologist, so to check the solo evaluation. And you know the pathophysiology here, the rheumatoid spondylitis is subdivided into the three categories: the atlantoaxial instability with rheumatoid pannus, basilar invagination, superior migration of the odontoid, and the subaxial subluxation. So the rheumatoid arthritis is an autonomic condition in which synovial cells produce rheumatoid factor, and this initiate an inflammatory cascade with immune complex deposition and leukocyte infiltration in the joint. So the fibroblast proliferation create granulation tissue, which is called the rheumatoid pannus, and which erode the surrounding bone and connective tissue, and especially the cruciate ligament. And through proteolytic enzyme activity, the end result is the ligamentous laxity and the atlantoaxial instability and the basilar invagination. The hypermobility that occurs within the occipital atlanto complex produce further inflammation and arthropathy up to 80% of the patient with rheumatoid arthritis, and develop radiograph evidence of the cervical spine involvement. Treatment options here we have medical immunotherapy, or such as the TNF inhibitor and the monoclonal antibodies, NSAIDs, corticosteroids, mechanical cervical orthosis does not alter the disease course but mainly protective, and interventional such as the nerve block useful for the patient with isolated occipital neuralgia, and the surgical here the anterior odontoidectomy and traditionally performed through the transoral route with the high morbidity, and specific complication include infection and velopalatal insufficiency. Endoscopically assisted expand endonasal approach and enable access to the anterior C1 and C2 complex with lower morbidity, and is ideal for the severe anterior compression. Posterior decompression fusion allow for the rigid fixation of the occipito-atlantoaxial complex if minimal osseous destruction. A C1 and C2 fusion alone may suffice, and significant osseous destruction warrant a large construct from the occiput to the subaxial cervical spine. For mild and the moderate or the anterior compression, posterior fixation alone often lead to the pannus regression and stabilization. For traction, you know that the Gardner's well tongue may be an effective mean of reducing basilar invagination and indirectly decompressing the cervicomedullary junction. If successful reduction is accomplished, a posterior only approach is often sufficient. Surgical technique here, you know the positioning is and positioning is supine with Mayfield head holder applied and the head translated anteriorly and slightly flexed and rotated 15 degree towards the surgeon side, and the standard, if we say the standard exposure with removal of the middle turbinate and the bilateral sphenoodontoidectomy and the detachment of the posterior nasal septum from the rostrum boundaries and the full of the sphenoid rostrally, so the use chicken tube laterally and the soft palate quadrally. And this actually endoscopic endonasal approach for the for the decompression, it is a very valid and very good option, and so we should use that, and it is very helpful for such cases, and it is really you can decompress with that approach also. So the nasopharyngeal mucosa is incised and the soft tissue are dissected laterally from the clivus down to the anterior ring of the C1 and then removed with the high-speed drill, and the pannus and the odontoid are resected with an ultrasonic aspirator or high-speed drill, and reconstruction is accomplished with the fibrin glue. And this is a very, an easy to get this, and I have experienced this expanded, we can say, nasal approach is very well, and this endoscopic transnasal approach for resection of the odontoid process is really a very good approach. I want to show you one thing. If you see this, you can see it's a very easy to go, and I have experienced this and I did this procedure multiple times, and initially when I did first time, definitely it was a little strange at the strange feeling, but with the time, as I did multiple times, and that I got confidence too much in that, and now I think this kind of the procedure when I'm doing, usually this is a treat for me to do that. So you can appreciate from here, there is a direct view, and you can approach exactly on the basion and the occipitovertebral junction from anterior, and it is not difficult at all, because I did multiple time, and I must tell you it's a very good and very, if you have a good instrument, then you can do very well. So as I mentioned here, that the Dingman retractor you can apply here. This is called the Basilar Sontage retractor, and you will appreciate here. This is the Basilar Sontage retractor, and actually it is not available everywhere. That's why I carry with me, and it is my own retractor, because when I'm doing these kind of procedures, so these retractor are actually very helpful. And I bought from Pakistan, Karachi, and it was not very expensive. And because and even though I am working outside the Pakistan, and I did most of the cases these kind of, or you can say all of these kind of odontectomies out of the Pakistan, and it is very well done up till now. I'm not telling every patient like that. Definitely the neurology is different thing, but well done in that regard, that the procedure point of view, it decompresses anatomically, radiologically. You can appreciate these kind of cases, and still they are on my Facebook if you want to check this. This retractor, as I told you, that I have that kind of retractor, and I am using that, and the same procedure same step. It is very good diagrammatic option, and this is called the Spessler Sontage retractor, but and a Dingman retractor also like that, and it is working very well, and it is very stable, and actually most of the surgery, if you can appreciate this surgery, if you have a good retractor like this, then you can perform a very good surgery. And I am usually doing with the, first of all, I am doing the tracheostomy by myself, and then I am doing the procedure. So this linear incision is made in the pharyngeal fascia above the rhumatoid. You can palpate with the finger and confirm with the X-ray, and then you can proceed for the this incision. Once you give the incision, and now you can appreciate here, there the C1 ring is removed with the high speed drill or with the high quality small punch or nibbler, and the few people are comfortable with the drill, with few people are comfortable with this punch or like that, but I usually start with the punch and the nibbler, and then I usually proceed with the drill. So friends, here I want to tell you about something about the posterior approach, and actually the positioning in prone is in a Mayfield holder with the head in a military tuck position, and this occiput and the posterior element are exposed, and the caudal extent of the fusion construct in dependent on the several factors. So the lateral mass anatomy and degree of the kyphotic deformity and the bony quality is very important. C1 and C2 laminectomies may be performed, and the C1 screw are placed, and the sulcus arteriosus is located on the posterior arch, and the vertebral artery is identified. The inferior edge of the C1 lamina is removed, and the laterally exposing the lateral mass, and C2 DRG, and this C2 is mobilized inferiorly or sacrificed, and the medial wall of the lateral mass and the medial aspect of the transfer foramen are palpated to visualize screw trajectory, and the starting point is the center of the lateral mass. Under fluoroscopic guidance, a low speed drill is aimed and the 15-degree medially and cranially towards the anterior tubercle. The screw is placed bicortically, and the several millimeters proud to properly align with the C2 screw, and the C2 screw are placed in the pars interarticularis or the pedicle, and the starting point of the pars screw is 3 millimeter rostral and lateral to the inferior medial inferior articular process, and the trajectory is directed cranially toward the anterior ring of C1 and 20 degrees to the 30 degrees medially. The entry point for the pedicle screw is approximately 2 millimeters superior and lateral to the pars screw with less craniocaudal and more medial angulation. For subaxial screw, the lateral mass is bisected horizontally and vertically and creating 4 quadrants. The starting point is 1 millimeter medial and inferior to the midpoint, and the modified Magrill technique, if you know that the modified Magrill technique showing that the starting point is 1 millimeter medial and inferior to the midpoint, and the starting point is marked with the high speed drill. To a low speed drill is used to create a pilot hole aimed to the superolateral corner of the lateral mass, but the high speed drill will give you can apply a rough mark, then you can know from which area to which area you have to proceed. The starting point is marked with the high speed drill, as I mentioned, and the low speed drill is used to create a pilot hole aimed to the superior lateral corner of the lateral mass, but occipital plating is performed last because it can be altered to facilitate alignment with the cervical screw. The plate screw construct is affixed inferior to the inion and superior knuckle line, so the bicortical purchase is optimal. Here I want to show you something. If you can appreciate this picture and you can realize how we are working with the drill, and there is you can use that support for the drill, so you cannot go here and there, and you can avoid to slip. But the low speed drill will help you to make a pilot hole, and with this pilot hole you can get the entry safely and confidently, and which will not cause you any difficulty here. So with this way you can enter in the lateral mass screw, you can put and you can get the lateral mass screw entry in the C1, and then definitely you can proceed further procedure. Here if you can see that there is a various starting point and trajectories for the C2 pedicle screw, and you can appreciate the width trajectory is helping you, and you should not injure the vessel, any important vessel or nerve here. This picture will tell you a lot of story, the degrees. You can see there, if the 30 degrees, where are you going? If the 10 degrees, where are you going? If the 25 degree, where are you going? And in the simultaneously, there's a McGrill says there it is a 25 degrees is good, and Anderson is telling there the 10 degrees is good enough, but you can hit the vessel. And but the nth degree, nth is telling it's total different story, and he is telling there the 30 degree is okay. So with this picture you can get a lot of idea, you can make the 3D picture in your brain, and then you can in your mind, and then you can apply accordingly. Either you are agree with the McGrill, either are you agree with the Anderson, or either are you agree with the ENS technique. And these all are very good techniques. There I have some positives and negative, and then it will help to do these kind of posterior fixation in basilar, invagination, rheumatoid, pannus. I want to show you here there's the occipital plating system with the rod connector to the cervical spine instrumentation, and it depends upon the length when you are involving the C1, C2, C3, C4, C5 here, and with the occipital plating the whole complex is good, but I don't know how much you go. So I am thinking just to get the stabilization, and how much the disease involved, the quality of bone, how. If the quality of bone good, then definitely you can, and with the smaller complex of the titanium screws and the lateral mass screws and the rods. For this expanded endonasal approach, lateral cautery dissection at the level of use-taken tube must be performed, and careful to avoid injury to the retropharyngeal carotid arteries to avoid CSF leak. The odontoid is cored out ventrally and then dissect from the transverse and the apical ligament. In posterior approach, the head must be optimally positioned for the horizontal gaze and bipedal location, and the electrocautery is avoided during lateral dissection along the atlas to prevent vertebral artery injury. And if the vertebral artery injury occurred during the placement of the C2 screw, the screw is left in place and the injured vessel is packed off and the wound is closed expeditiously without contralateral instrument, and immediate post-operative angiography is performed to create the injury, to treat the injury, I beg your pardon, to treat the injury and followed by an stroke protocol MRI. So this is all now for the. I can talk more about this, but I want to be limit myself this video for the basilar invagination for the rheumatoid pannus, but I must talk about in another video with the same topic or related topic if I must need. I hope you will like this, and if you like it, I am Dr. Mohammad Kazafi, and you are watching Dr. Mohammad Kazafi Views. So please subscribe, share, and support us. Thank you so much.